Welcome to Raaonline. So today we are going to see a very important topic, the tumor lysis syndrome. Okay. So can you identify this gentleman? We'll identify him a little later. Okay. So now coming back to your tumor lysis syndrome. You need to know which tumors can go in for tumor lysis syndrome, right? More commonly it is going to be your ALL, the Burkitt type of lymphomas are these tumors which can go in for tumor lysis syndrome. Or if the WBC count is like more than 50,000 in kind of leukemias, they will go for tumor lysis syndrome. Or any tumor that has very high proliferation rate, they will go for tumor lysis syndrome. Okay. So when exactly is that? For example, you have a big solid tumors and there's a feeding artery. As a treatment, you're going to do something called as a arterial embolization. So when you do an arterial embolization, ultimately the tumor burden is going to get reduced and they can go in for tumor lysis syndrome. Or as I told you, when the WBC count is like more than 50,000, that is the tumor burden itself is very high, they have high proliferation rates, they have high turnover rates, so they can go in for tumor lysis syndrome. Or you have started the patient on chemotherapy, then also the patient can go in for tumor lysis syndrome. Okay, so how will be the presentation is, the patient can present with muscular weakness, the patient can have cardiac arrhythmias, the patient can have renal failures. Okay, so why the patients are having this kind of renal failures and cardiac arrhythmias is that when there is a tumor cell, you need to understand the phosphate concentration in the tumor cell is 4 times more than the normal cells. Okay, the phosphate concentration is 4 times more than the normal cells. So when the cell ruptures, when the cell dies, the phosphate comes out, right? So along with the phosphate, the nucleic acid comes out, and also the intracellular ion, the potassium comes out, right, along with other ions also. So this phosphate binds with calcium, so that causing phosphate, calcium phosphate, so the calcium comes down. So there will be low calcium, high phosphate and high potassium. Okay, eventually this nucleic acid will also get metabolized into hypoxanthine, xanthine and ultimately uric acid. So there will be more uric acid. Okay, so increase in uric acid, decrease in calcium, increase in phosphate, increase in potassium is what actually happens when the cell lies. Okay, so how are you going to treat this patient? One, you can anticipate prophylactically that this kind of tumors can go in for TLS, and you can start your treatment even before the TLS occurs, and you can hydrate the patient, and you can take measures to decrease uric acid formation. You can take measures to remove the already preformed uric acid. You can take measures to improvise your potassium. You can take measures to improvise your calcium, phosphate and other supportive therapies. So this is what we are going to see in our presentation as tumor lysis syndrome. The tumor lysis syndrome is an oncologic emergency that is caused by massive tumor cell lysis with the release of large amounts of potassium, phosphate and nucleic acids into the systemic circulation. Catabolism of these nucleic acids to uric acid leads to hyperuricemia. This hyperuricemia causes AKI, acute kidney injury, that precipitates in the renal tubules, renal vasoconstriction, impaired autoregulation, decreased renal flow and oxidative damages, inflammation, ultimately resulting in acute kidney injury. What you need to know is when the cell ruptures, the nucleic acid comes out. This nucleic acid by metabolism turns into uric acid. Thus uric acid damages the kidney, causing acute kidney injury. Okay. So now from the same cell, the phosphate comes out. It binds with the calcium, causing calcium phosphate. This calcium phosphate gets deposited in the renal tubules, and it also was calcium phosphate deposited in kidneys, causing acute kidney injury. Understand that this calcium phosphate gets not only deposited in the kidneys, it can get deposited in other organs as well, like cardiac. And the uric acid precipitates more readily in the presence of calcium phosphate, and it's a vice versa. So when there is more calcium phosphate, it itself can affect the it itself can affect the kidneys. Moreover, it can increase the toxic effects of uric acid so that the acute kidney injury worsens and vice versa. So now coming to which tumors exactly. Clinically aggressive and highly aggressive lymphomas, that is the Burkitt's subtype, or the T-cell acute lymphoblastic leukemias, the ALL, or any tumors which have a high proliferative rate or large tumor burden, or they are very high sensitive to cytotoxic therapy when you initiate a chemotherapy, all these tumors are more prone to develop TLS, that is tumor lysis syndrome.